All right. Good afternoon, everybody. Thank you guys for joining. Today, we're going to be talking about three different services we offer that kind of fall under the antimicrobial stewardship umbrella. So conveniently, we've named this AMS, OPAT, and COpAT, making sense of alphabet soup to best serve your patients. My name is COtessa Howard. I am our lead antimicrobial stewardship pharmacist for the WVCTSI health system. So I will be talking about the first part of alphabet soup, AMS, or antimicrobial stewardship. On the next slide, you will see some objectives that we have listed. So really, the purpose of today is we're going to define these different programs and describe how these services intertwine to provide best patient care across the continuum between inpatient and outpatient. So next slide, we're going to start, like I said, we're going to start with the patient care across the continuum. So this is a very watered down look at a patient journey. And this is what we're going to take you guys through today with the various services, with the different presentations that we have. And as you can see here, as a patient comes inpatient most often, a patient may be identified to need antimicrobials for whatever duration. And if they need those antimicrobials in the outpatient setting, that is where we can help provide best care around those with our specialized OPAT and COpAT programs, which we will talk about later in today's presentation. But you can see here where the journey starts. Antimicrobial stewardship programs often are the first program to touch these patients, the first program to review the patients. And then as we're gearing up for discharge, that's when our OPAT and COpAT services come into play, and the outpatient too, all the way until these antibiotics or antimicrobials complete and the patient's completed their therapy. All of this will make much more sense once we go through this, but this is just to orient you to how these services interplay as we go through the presentation. Next slide, please. So now we're going to start with defining what antimicrobial stewardship is. So out of the three different acronyms I've listed, this one is probably the one that you guys are most familiar with. Antimicrobial stewardship has been around for a while now, but a lot of times, even though it has been around, or maybe the settings that you work in have antimicrobial stewardship programs, the true definition of what those are sometimes gets lost. So I just want to take us back to exactly what stewardship is. And if you look at the definition of that, it's the job of supervising or taking care of something, often a finite resource. So you might hear that someone is a steward of lands, a steward of, we have like opioid stewardship, we have antimicrobial stewardship. So looking at the consensus definition from various organizations in the infectious diseases world, antimicrobial stewardship is essentially coordinated interventions designed to improve and measure the appropriate use of antimicrobials by promoting the selection of optimal drug regimen, including dosing, duration, and route of administration. So taking that into consideration, if we look at the next slide, I break that down, and that's kind of what I call our antimicrobial stewardship mantra. So if you've heard me ever give a presentation before, I think I include this in every single one. It's the right antimicrobial for the right bug at the right dose and the route for the right duration. So stewardship is just ensuring the appropriate use of antimicrobials. Antibiotics really changed the course of medicine, but they have to be used appropriately. So that's really what we try to do with our programs. So just keep that in mind as we go through the rest of the slides today. So next slide, please. And everyone is an antimicrobial steward. So no matter what setting you practice in, whether you are an infectious diseases specialist, if you're an outpatient care provider, family medicine, nursing, and if you have a patient who's on antimicrobials, you can be a steward. And that's another thing that I just like to promote. We all have a role. Next slide, please. And then, even though you may have heard of this at your hospital or the institution that you work in may have a stewardship program, why do we need these? And there's many different reasons. I could go on about this for hours since it's what I do every day. But there are studies that indicate that up to half of the prescribed antibiotics, particularly in the inpatient setting, are suboptimal. So we are prescribing antibiotics, but often we're not prescribing the right antibiotics. Often we're overusing them as well, and antimicrobial misuse can contribute to unfavorable outcomes. One that we hear a lot about is Clostridioides difficile infections, or CDI. And then antibiotics are a very finite resource. We have a very limited selection, and new antibiotics don't get put out to market very often. So the more we use antibiotics, the more we select out multi-drug resistant organisms, which is a problem because we don't have new antibiotics coming to market that often. So we really need to steward the resources we have to protect their use for the future. And there have been a ton of studies that have shown the benefits of stewardship, but to kind of sum those up, taking into account the suboptimal use and what can happen with misuse of antibiotics. Many benefits such as decrease in antimicrobial resistance has been identified. We promote patient safety. The more you have stewardship involved, the better outcomes for certain infectious diseases. And then, of course, we optimize our resource utilization by using this niche of drugs very selectively. Next slide, please. And a little bit about, I do want to take a step and understand why this is so important to our state of West Virginia. As a West Virginia native, this hits very close to home for me, as many of you sitting here at the desk today and on the call. But the CDC puts out statistics every few years. I think the most recent for the outpatient antibiotic prescriptions was data from 2021. And if you look here, the national average, so how many antibiotics were prescribed per 1,000 people, was around 630. If you look at West Virginia's numbers, we are second highest in the nation, with almost double that national average. So in the year 2021, we had more outpatient antibiotic prescriptions than people in the state of West Virginia, if you look at that, which to me, that really resonates, because it just shows that we have a lot of work to do. We also have a very sick patient population if you're practicing in the state, but also there's a lot of work to be done on this. And even if you're not working in an outpatient setting, there's ways that you can impact this on the inpatient side as well. So that's our outpatient use. On the next slide, you can see inpatient use in antibiotic. If you just hit next one more time, Jay, some numbers will pop up. So in the inpatient side, what a lot of hospitals do is we report our antibiotic use to the CDC through their National Healthcare Safety Network. That's going to be a requirement of stewardship programs that participate in CMS moving forward this year. So we'll have better data on this in the years to come. But of those hospitals that were reporting in West Virginia had the highest standardized antimicrobial administration ratio in the year of 2021 out of all the states. So we were using above what is expected of our use compared to what the CDC puts out there. I'm not going to get into that too much in depth, but just so you can see that our inpatient antibiotic use is also higher than the national median and what is expected of us. So a lot of work to be done in our state. Just put that out there. Next slide, please. And having an antimicrobial stewardship is best practice and required. So if you click next just a couple of times, Jay, you'll see here all of the different regulatory bodies that have put out information on stewardship requirements or stewardship best practices. So up until about 2015, antimicrobial stewardship was something that was promoted, but not something that we had to have. And then in 2015, the White House put out this plan for combating antibiotic resistance, which was then followed by, in 2016, implementing stewardship program. Guidelines were put out by the Infectious Diseases Society of America and SHEA. The Joint Commission followed suit in 2017, requiring stewardship programs for inpatient hospital settings that are Joint Commission accredited, and that was most recently updated in July of 22. And then I believe in about 2015, 2016, the CDC started putting out core elements for antimicrobial stewardship programs for the various settings. that are listed on the screen. So this is best practice. If you're a hospital that is Joint Commission accredited, it is a requirement to have this program. And there's a lot of great resources out there if you're looking to start a program or beef up the program you already have. Any of these are really great. I am going to focus a little bit on the Joint Commission. So if we hit the next slide, you can just see here that there are 10 revised elements of performance that hospitals and critical access hospital programs should have. And these were updated in 2022 to really focus on the best practices that a stewardship program should have in place. And we'll talk a little bit about one of those in a subsequent slide. But that's just there for your reference. The next slide is also for your reference. This is just a brief description of the CDC core elements. But it talks about the different things you need in place to make your stewardship program successful. Next slide, please. So what I am going to give you an example of is the antimicrobial stewardship workflow that W Medicine facilities have put into place. So we take a tiered approach by looking at the what we call our top tier alerts, like our patient safety net alerts. And these are things, those are our number one priority that we look at every day. And these are things like bug drug mismatches, positive blood cultures, and then bloodstream rapid diagnostics. And then you can see we have lower priority of alerts, tier 2 and tier 3. Once we get done with those, we would focus on the lower priority alerts. And this just helps us stratify which patients may need most critical intervention versus what can just be looked at a couple times a week, like patients who may be on HIV antiretroviral therapies. So this is just an example if this is something that you're wanting to put into place into your hospital, what you can focus on. But as you see, positive blood cultures is italicized and bolded. That was a specific recommendation out of the new Joint Commission updates. So we built a way in the W Medicine system to review all patients with positive blood cultures. And what I want to show you is an example of how a stewardship program reviewing positive blood cultures can really streamline therapy and set up our patient for the best success and how that ties into our OPAT and COpAT programs. So I'm very briefly going to walk us through a patient case starting on the next slide. So I'm going to start with how this patient case presented and the antimicrobial stewardship review. I'm going to be super brief with this. My physician colleagues go into a lot more detail, but I just want to show the importance of the different programs, really. So we had a 51-year-old male admitted to West Virginia University Hospital on September 19th with a concern for necrotizing fasciitis. His blood cultures obtained on admission, you can see on the screen here. They returned back with Staph aureus, and then we do have a rapid diagnostic that will tell us within 2 hours of gram-positive cocci and clusters identified on a blood culture gram stain if that is Staph aureus and if there is methicillin resistant suspected or not. So within 2 hours, we knew if we were treating MRSA or MSSA in the blood, which is very critical in getting on that targeted antibiotic therapy very quickly. And the traditional susceptibilities often take 48 to 72 hours. And as you can see, those are listed on the image on the left-hand side there. So these blood cultures were obtained. The stewardship team was alerted and reviewed the patient. On the next slide, you can see a little bit more about the case here. So the stewardship team gets alerted almost immediately of that blood culture positivity. When we reviewed the patient was on broad spectrum antimicrobial therapy with vancomycin, piperacillin tazobactam, and clindamycin. The stewardship pharmacist, like I said, we were alerted by the positive blood culture review. We reviewed the patient and recommended the following. So we recommended the antimicrobials be switched to cefazolin for targeted MSSA therapy. There is a good amount of data out there that shows that vancomycin for MSSA is suboptimal. So it's just a way, putting it out there, we're getting patients on targeted therapy very quickly. We recommended repeat blood cultures to ensure clearance of the bacteremia. And we also recommended ID consultation. So with Staph aureus bacteremia, there's a lot of good literature out there that shows that antimicrobial stewardship and or infectious diseases consultation being involved leads to better outcomes for the patient. So that's what we recommended for the patient on our first glance. If you can go into the next slide, I'm just going to show you a few dates and kind of how the patient progressed over time. So the patient was admitted on 9/19. The stewardship team reviewed his blood cultures as soon as we were alerted to them and made recommendations that I just previously mentioned. On the 20th, ID was formally consulted and made their recommendations, and then completed additional workup that was needed, which I won't go into. So that was that piece that was done at the very beginning of the patient's therapy, almost immediately upon admission when we had the results back. If we go on to the next slide, you can see that OPAT, COpAT, so outpatient parenteral antimicrobial therapy and complex outpatient oral antimicrobial therapy was consulted with the plan listed on the screen here. There was a plan to complete the IV antibiotics for the first 2 weeks of therapy, and then pending how the patient was doing, switch over to oral antibiotics to be monitored with COpAT for the last 2 weeks of therapy. That switch to oral therapy was going to be really hinged upon how well the patient was doing, their laboratory values, and follow up with the infectious diseases physicians in clinic. So that was the plan put into place. If we go to the next slide, we can see the dates listed here, and this is very, very brief. But as you can see, on the 25th, OPAT, COpAT was consulted. The 29th, the patient was discharged to the skilled nursing facility. So the plan was originally to switch to oral therapy after 2 weeks of IV. However, due to that really close follow-up by the OPAT and COpAT teams, the IV therapy with cefazolin, it was prolonged due to that elevated CRP until the patient could be seen in clinic, which was done on October 16th, and the patient was doing well then. We switched over to oral antibiotic therapy, and then ultimately the patient completed a total of 6 weeks of antibiotic therapy with the oral therapy. So I really like this case because it shows that stewardship can get on targeted therapy very quickly, make recommendations for ID consultation when appropriate. We got the patient set up for a great plan at discharge, but sometimes plans change and can change and should based on the patient's clinical progression. And due to really close follow-up by our infectious diseases physicians, our OPAT and COpAT programs, the patient was able to have the therapy altered a little bit, but ultimately got the best care and still got to have an IV to oral antibiotic switch. So just a great case about patient care across the continuum for our teams. And now I'm going to turn it over to Dr. Johnson to talk about OPAT a little bit more in depth.
So like Katessa said, we're kind of alluded to, OPAT and COpAT are under stewardship. So antimicrobial stewardship is our defining kind of role with OPAT, then a branch off of that trunk, if that makes sense. So our OPAT program is pretty well established. Our goal is to ensure that all patients discharged from Ruby on intravenous antimicrobials complete treatment safely and effectively in the outpatient setting. And there's a lot in that definition, with one of those being, okay, can we help patients stay out of the hospital? So can we manage some of these adverse outcomes without having the patient readmitted and have a good outcome? Like I said, our program was established in 2017, but since then it has grown tremendously. I took over as the physician. This will be my 3rd year. And Jay, you can continue to click through. And we have multiple pharmacists who help with our program and rotate through. We have 6 ID pharmacists total. I'm the physician. We have 1 nurse, Crystal. Brenda just retired, and then an administrative assistant. One thing I like to point out about both our OPAT and COpAT programs is it's a multidisciplinary team at its finest. So Anytime I have a patient issue, I bring it to the team. There are times that the nurse will give recommendations, the pharmacist give recommendations, because we all know something about each of our patients, and having that story kind of combined to make the best plan moving forward is always a good idea. So here's a picture of our team. We're a good looking group, as you can tell. You can keep looking. And like I said, our program is large and well developed. We've helped develop programs all over the United States, places like Johns Hopkins, places down south. Our program is really looked at as a model at this point. Since its inception, it's had about 8,000 to 10,000 patients total. Clicking through, Jay. So these are some pictures more of kind of my role in OPAT. So I often will work remotely, and we use technology to communicate. I encourage my pharmacists to reach out to me through the Epic chat, as well as all the home health nurses that I deal with at any time. This is just a great feature that we use to communicate so that I can provide real-time care kind of at the moment when they're at the patient's house. If they have an issue, they can chat message me. If they need to call me, they often will have our phone number and can call in. But again, just trying to provide that care as quick as possible and optimally. COpAT already had a great picture of this. Jay, you can continue just to click through. So we have our inpatient, our patient that's admitted to the hospital. The OPAT team is consulted. We write a note, create a plan, discuss it with the inpatient team. We continue to click through. And then we follow our patient to the outpatient setting, and that's regardless of where they go. A lot of our patients do go home. However, those that go to a skilled nursing facility, a nursing home, an acute rehab, we follow all of those patients and provide help with their antibiotics. Really, until their line is out or their transition to PO antibiotics, we're involved in their care. Another thing that we do is ensure that they have follow-up. So that might be, if for instance, they don't have an ID follow-up in person, that might be me doing a telephone visit, again, just to make sure that all of our ducks are in a row so that the patient has the best outcome. And this is a intentionally busy slide. So where is OPAT? This was just when I went through our list, all of the places, home health companies, skilled nursing facilities that represented just 50 of our patients that I randomly selected. Again, just showing that we provide care to patients all over the state, even outside of the state if they're from neighboring states. And no matter where they go, we kind of follow along as much as we're able to, and a lot of these facilities and things like that are very much aware of us now, and they appreciate our input as a program that's really just there to help any way we can.
Any questions before we go to Joy? Just wanted to make sure. Feel free to use the chat. For those who joined during the presentation, please go ahead and drop your information into the chat for introductions, looking for your name, your email, and your organization. But if there aren't any questions, Joy, let me get your slides pulled up here.
Maybe I can give a context here as to what was the world like before OPAT COpAT. So on the ID consult service, we used to get faxes on the weekends from about 20, 30 patients. That was part of the responsibility of the ID team to look at and to chase the labs and to chase the patient. So what these programs have done is, by being patient focused and making sure that the patients are getting the treatment they need, modifying the treatment when that is needed, they've created a seamless transition to getting outcomes that are way better than we used to see. So it was the luck of the draw whether your patient completed their 6 weeks or 4 weeks. It was the luck of the draw whether they got the prescription antimicrobial you sent in, because you never had the resource to follow up on. Was there a big copay? Did they just quietly stop taking it? Those kind of things. So I think of these as really good safety net programs that have enhanced patient care for those that need prolonged antibiotics.
Transition to COPAT. What is COPAT? It's complex outpatient oral antimicrobial therapy. And I'm Joy, or Dr. Justwich, the medical director of our COPAT program, and I've partnered with Dr. Sawari. We're both the physician leaders of the COPAT program. So for this talk, I'm going to give a brief overview of literature, talk about our COPAT program, and then share a COPAT case. So again, defining COPAT. COPAT is using oral antibiotics that achieve high blood levels or have high bioavailability in place of IV antibiotics. And there's evidence for using COPAT for our two hardest to treat infections, and that's bone and joint infections and endocarditis. And there are two landmark studies that were published in the New England Journal of Medicine in 2019. We've had evidence for doing this for several years, and now we're implementing it in our practice. So the first clinical trial is called Partial Oral versus Intravenous Antibiotic Treatment of Endocarditis, or the POET trial. And this study showed that in medically stable patients with left-sided infective endocarditis from gram-positive organisms, intravenous to oral antimicrobial transition after a minimum of 10 days was non-inferior to continuing intravenous antibiotic therapy. Next slide. So initial conclusions of the POET trial were drawn after 6 months, and 5-year outcomes of the POET trial are now available. Jay, you can click again, please. This shows that there's actually a higher survival, so lower mortality, and no indication of longer-term treatment failure in the patients that were transitioned from IV to oral antibiotics early. And here are the graphs, and you can actually see that the survival drove the composite primary outcome as being better in the IV to oral antimicrobial treatment or transition group. Go ahead, Jay. So the second trial is the oral versus intravenous antibiotics for bone and joint infection, or the OVIVA trial. And this showed that when used for complex orthopedic infection, and this can be gram-positive, gram-negative, culture-negative, intravenous to oral antimicrobial or antibiotic transition within the first 7 days was non-inferior to continued intravenous antibiotic therapy. Go ahead, Jay. So the WVCTSI, or our COPAT program, really started in the setting of COVID-19. So the COVID-19 pandemic peaks resulted in shortages of hospital beds, and this led us to find ways to decrease length of stay and open bed capacity. And we had a leadership email that really encouraged us to minimize the use of intravenous antibiotics requiring inpatient stays, to consider oral antibiotics and early IV to oral antimicrobial transition. Next slide. So again, what is our COPAT program? So this is an interdisciplinary team established in 2021 that provides monitoring and adherence counseling for select patients on oral antibiotics in the outpatient setting. Goals of the program are to optimize patient care,
by preventing hospital admission, avoiding need for intravenous access, and facilitating earlier hospital discharge. And as you can see, it targets various serious infectious diseases. The one that's not listed on this page are CNS infections. And this is just because there isn't literature, or there haven't been studies supporting it, as there have been in the other types of studies. So we're still getting the literature in that area. So how does our COPAT program work? So patients are identified as candidates if they're receiving oral antibiotics for at least 2 weeks, that are, we have an oral antibiotic appropriate for the infection type and pathogen. And the patient's willing to take oral antibiotics and then comply with lab testing and follow-up. COPAT consult order is placed in EPIC. And here, this triggers review by infectious disease pharmacist and an infectious diseases physician. So notes placed in the chart with the antibiotic regimen, the duration, the outpatient laboratory monitoring plan, and then the plan for follow-up. Antibiotics are dispensed, and then our COPAT team calls the patient for medication reconciliation, usually within 2 to 3 days of hospital discharge, and then weekly to discuss adherence, side effects, and lab results. And then the patient follows up in COPAT clinic in 2 weeks. What are some of our outcomes? So this is just a brief overview of our first 280 COPAT patients, and this is between December 2020 and December 2022. It should be noted that as of December 2023, approximately 625 patients, so another 350, have completed our COPAT program. Go on to the next slide. So as you can see, COPAT program includes treatment of patients such as those with injection drug use and bacteremia. And next. And for infection type, the most commonly treated are bone and joint infections, 42%. Mixed etiology, which in this case was a combination of bone and joint infection and endocarditis in 15%, and then endocarditis in 13%. And if you add those together, that equals about 70% of the patients that fall into those 2 studies that were published in the New England Journal of Medicine. So right, endocarditis and bone and joint infection back in 2019. Next slide. These are some of our early clinical outcomes, and this is just to show that patients do participate in follow-up, and these numbers I feel are higher now as far as reaching them through telephone check-ins and follow-up in infectious diseases clinic, but they do well, right? So Jay, you can click again, please. And you can see our 30-day readmissions and then our COPAT-related readmissions. So any readmission related to the initial infection or the antibiotics are very low. Go on. So in summary, our experience here shows that when offered, patients prefer oral antibiotic options. So we're finding now, when we do give the patient the option, for that their infection can be treated with either IV or oral, they don't want the PICC line and they're requesting to be discharged on oral antibiotics. Our COPAT program is safe and clinically effective and also results in significant cost savings. And further expansion of our COPAT program is underway. So we are doing a clinical trial. It's called Comparing Oral versus Parenteral Antimicrobial Therapy Trial. And this is a multi-site, pragmatic, randomized controlled trial. So this is being conducted across 5 WVU medicine hospitals with ID faculty. We're enrolling approximately 135 patients. This is designed to demonstrate safety superiority with equivalent effectiveness of earlier transition from IV antibiotic therapy to COPAT. And again, this is being conducted across most serious infectious diseases, with the exception being the CNS infections. And our other focus is the WVU medicine system-wide and statewide COPAT program. So our goal is to develop COPAT programs like ours in hospitals with ID faculty, and we're doing this through our COPAT trial. And then a COPAT IDE consult programs for hospitals without ID faculty. And we've started this with a very successful pilot program with Princeton Community Hospital. And then our WVCTSI project ECHO that we're doing today, statewide antimicrobial stewardship, OPAT and COPAT. So thank you, and I can transition into the case, or if anyone has any questions or points for discussion before then, feel free. I go ahead and to our case and then open it up for discussion about all the programs. Okay. So this is just one example of a COPAT case. This is a 57-year-old male that we recently saw here at Ruby on January 4th. You can scroll down, and if you don't mind going down just to the history of present illness, I'll start with that and then go back up to which antimicrobial therapy and why. So this patient was admitted to our facility December 30th through January 4th with a diabetic left foot infection with first toe and metatarsal osteomyelitis. And he had previously been evaluated. He was treated with short course of oral antibiotics, and he had established care in podiatry clinic. So then he was ultimately admitted to our hospital, and blood cultures were negative. Had a superficial wound culture that grew multiple gram-positive and gram-negative organisms. Had an MRI of the left foot on New Year's Day that showed osteomyelitis of the first distal phalanx, proximal phalanx, and distal metatarsal. And he ended up undergoing left partial first array amputation for source control on January 2nd. Intraoperatively, there was a necrotic first toe, purulent drainage, malodor, and then the first metatarsal head appeared discolored and soft. And then the first toe, metatarsal head, and sesamoids were resected, and then intraoperatively, there was no gross evidence of any residual infected soft tissue or bone. So operative aerobic cultures grew multiple gram-positive and gram-negative organisms, and then operative anaerobic culture grew mixed anaerobic flora, so clearly polymicrobial process. And the patient was on vancomycin, cefepime, and metronidazole at the time of evaluation. He made it very clear that he didn't want to be discharged with a PIC or a midline. So kind of going back up, what antimicrobial therapy would you propose and why? So one option we proposed would be moxifloxacin, and this provides good polymicrobial coverage, including anaerobic coverage, in absence of a history of MRSA. It is a once day, so an easy, simple regimen. It has high or 90% bioavailability. And for example, in this patient's case, we thought he had good source control with very low concern for risk of positive surgical margins. But in the case that surgical pathology were to return positive, it's something that would be very easy to extend and well tolerated for longer duration. Keep scrolling down. So pertinent past medical history is mainly his uncontrolled diabetes. So his hemoglobin A1C was 13.8% or almost 14. He had stopped taking all of his medications, including his medications for diabetes, approximately a year ago. And so the medications listed here were those that were going to be resumed on discharge. No allergies. And for social history, it's pertinent just because it shows some challenges. The patient was from El Paso, Texas, and actually was living there until around the time of admission, but he did plan to stay around the area until completion of antibiotic therapy. He did have a history of smoking and did drink alcohol, had previously used some cocaine, and then had transportation issues. So had a significant other that was going to be going to Las Vegas the week after his hospital discharge, and then would be able to provide transportation if he needed labs or needed to attend follow-up once she got back. So for exam, he was afebrile, didn't look toxic. His left foot, when we examined him, was kind of dressed and wrapped and was being changed by podiatry. But if Jay, you scroll down to the bottom here, I'll kind of show the pictures and then skip to a little bit of the imaging. But this is his preoperative photograph of his left foot. So you can see something that clearly wouldn't be treatable with antibiotics alone, right? So pretty severe. And then this is his left foot postoperatively at the time of evaluation. So had a lot resected, very good source control. And this is also shown, and we'll show the imaging later, or go into the imaging later, but if Jay, you scroll down a little bit more, this is a parallel kind of photograph or radiograph or x-ray of his left foot postoperatively. So you can see it went kind of way down beyond the metatarsal head, kind of through the metatarsal. So, very good source control. If you don't mind going back up. Just a few more things about his case. So maximum CRP under labs was 160. At the time of evaluation postoperatively, it had already come down to about 60. And then I already outlined his microbiology and pathology. And at the time of evaluation, his surgical pathology was pending. The polymicrobial process. And for imaging, I'm not going to read through all of these, but in November, he did have a plain radiograph that showed no evidence of osteomyelitis. And then progression by January, he had an MRI of the left foot that did show evidence of osteomyelitis of the toe and first metatarsal. And he had a peripheral IV line in place. So a few questions for the audience just to generate some discussion after hearing our the presentations on our programs. What factors make this patient a good candidate for our COPAT program?
So he has an infection that's treatable with oral antibiotics. That's kind of the first criteria for sure. And then also some social factors, I think that would really lend itself to more of a PO course, even if, for instance, I was maybe leaning towards IV in a different case, I would feel uncomfortable with sending this patient out on IV antibiotics, or at least feel like he wasn't going to do well. So another good reason to put him on PO.
Agree there. I think a good source control, you said, and then the social factors, living in Texas, especially going to be around for a while, right? Some alcohol use, lack of reliable transportation, and things like that. So completely agree.
How old is he?
Sorry, 57. Any other reasons why we would enroll him in our COPAT program?
I think patient preference is starting to become relevant. As we begin to talk to patients about equivalence of antimicrobial options. I would prefer oral pain rather than a PICC line. So I think that's starting to play a role as well.
The patient who pulling in our COPAT trial from the presentation we had discussed the COPAT trial with, and he didn't want to enroll. He wouldn't enroll to take the chance of potentially getting a PICC line or a midline. So, so definitely patient preference in his case. Yep. And then I think the other point maybe to share here is polymicrobial infection rate, multiple gram positives, multiple grams negatives, mixed anaerobic flora. But we chose moxifloxacin. This is something that we don't have to target all the organisms that grow. He had good source control. We have a simple regimen that's oral. And then how long would you treat this patient and why? So had good source control, surgical pathology is pending.
Feel free to unmute and put your information in the chat. Sorry, Tessa, go for it. Just wanted to remind everybody.
No, that's great.
Another intro. Okay.
Kind of similar to what I talked about with like follow-up and like the AMS to OPAT to COPAT transition. Surgical, like I am a pharmacist, so reading surgical pathology is not my forte, but surgical pathology does take a while to come back. So I think it really best highlights how if you have a follow-up program in place, you can have someone, even if it's just the pharmacist looking to say, hey, this is bad. Like I don't know how many times I've asked probably all of the ID physicians, like, hey, can you take a look at this? Like, I think we're going to stop, but want a physician's perspective, or if it's positive, continuing. So just having that mechanism in place to follow up on those results, because sometimes those might get sent to the admitting provider or the surgeon who did the surgery, and may not always get followed up on appropriately. So how long to treat, really depending upon that. But a good thing to look at for sure, follow up on.
We ended up sending him out on moxifloxacin to complete 2 weeks post-operatively. His surgical pathology now has returned and it is negative. There's osteomyelitis in the resected, amputated toe, but not at the clean margin, what's left behind. So also ask the question, you know, is this someone we could have treated shorter, right? Skin is soft tissue 7 to 10 days, right? Based on what you have shared with us in another presentation.
Exactly.
So probably maybe a candidate for a short duration.
Good question, Joy. for him. I really like the simple antibiotic regimen, absolutely, one and done. I was just wondering if augmentin was discussed too. Does it provide similar coverage to moxifloxacin? The only reason I ask is the uncontrolled diabetes, sometimes fluoroquinolones can alter the blood glucose a bit. So just putting that out there.
Yeah.
Seeing if we thought about that too, or maybe.
I agree it was an option, in him, and someone with, where I would have more concern that there would be residual osteomyelitis, or if we're treating an osteomyelitis doesn't have good source control, I'd probably do the moxifloxacin for a little higher bioavailability. But in his case, I do think amoxicillin or augmentin would be a good option.
I agree.
Right, yeah, and we're being more aware of the interactions with fluoroquinolones, and especially with the diabetes medicines. So yeah, I completely agree. Augmentin would be a good option in him.
Awesome. I wasn't sure if there was like a penicillin allergy or not. So many of our patients have those too, but
Great, yeah, would be a good choice.
This is David. I got a quick question. When you're prescribing these antibiotics on the outpatient side, say for this patient, you were looking at possibly, 2 weeks, but you ended up cutting it shorter. Do you automatically prescribe them the 2 weeks and then tell them to stop, or do you always kind of do a week and then assessment, or after that, like what you think the minimum might be? How does the process work for y'all?
Good question, and I think this answer may be different from OPAT to COPAT. In this particular patient, we did prescribe the full 2 weeks. In a lot of the patients where we end up treating a range 4 to 6 weeks, depending on CRP normalization. When we have the longer duration, we'll send them out with the 4 week, the shorter duration. And then if their CRP doesn't normalize, I'll prescribe them more antibiotics. From my personal experience, patients where we've sent out on the full 6 weeks that are doing well at the 4 week mark and do have the CRP normalization, are a little more hesitant to go ahead and stop when it's appropriate if they already have the supply at home. And if they're doing well on the medicine, why not take a little bit more, and that can put them at risk, every day for a side effect or something like that. So it's much easier from a COPAT standpoint to extend them, keeping in mind that if it's something like linezolid that we're getting prior authorization for, to keep in mind when they're going to run out and be proactive if prior authorization needs to be extended. It may be a little bit different for the OPAT with.
So kind of for the IV side of things, because of the insurance approval and things like that, sometimes asking for more is better than less. But what we've established is just having really good communication with our infusion companies, because you're right that like patients do, like there's nothing more heart-wrenching than calling a patient to stop antibiotics who just got a shipment, and you're like, you don't need those, and they're like, but it's right here, it's right. and I hate and that's, so we try to communicate really well with our infusion company. Hey, they're approved for this much, but I have a good feeling we're gonna like shorten it to this. Or if you really, some of these diabetic foot infections and things like that, you can be pretty confident saying that your margins are going to be negative. Now, no one likes to, I always tell my patients, no one likes to gamble. I will never gamble on you, but if I was a gambler, I would have expected that patient's margins to be negative.
Yeah.
So in that case, I would probably tell the infusion company, hey, we're probably going to stop at the most at 2 weeks, just so they don't continue sending antibiotics that's not needed.
That's an area where OPAT and COPAT work close together, and you can see kind of the continuum of our partnership that I think has gotten a lot better as we've developed our programs. Is the patients that get transitioned from OPAT to COPAT, same thing as stopping. If they're going to go to oral, it's a lot harder to make that transition when they just got a shipment the night before of the next week of antibiotics. So our communication and communicating with the pharmacist early has made a big difference in successfully transitioning the patients from IV to oral in the outpatient setting.
I know patients that have like just got a new dose of bank and they're like, oh, but I have my old one. I'm like, you will get kidney injury if you continue this high dose. Sorry, David, were you going to tell? I think I
Oh, no, that's fine. That's good. Thank you for your clarification, because that's always one of those tricky, you don't want to have too much out there, but then sometimes costs could be in effect, if there's copay, especially like for an oral, they got to go get another 7 days of therapy. So I was wondering just how y'all did that. Thank you.
Thank you. guys brought up a great point with patients too. Like they're like, well, I have this, whether it's oral or IV, and it's making me feel better. Why can't I just take the rest of it? So one thing, you know, from all of our sides we try to do is highlight those harms like you talked about. And just saying, you know, well, you could get X, Y, Z, or, you know, C. diff. You don't want to scare people, but you know, there are harms with those. I think that's the thing we can do on the healthcare professional end for our patients too.
Any other questions or comments? All right, well, we appreciate everybody for the presentation. Contessa, Jess, Joy, Dr. Sorori, everybody, really appreciate great information. Again, you'll get all this after the session here. Be on the lookout for a recap email as well as the link to the recording. We will meet again on February 13th, where we'll look at endovascular infections. So be on the lookout for more information on that. But until then, have a great month and we'll see you soon. All right, take care, everybody.
Thank you.